Good afternoon everyone. I'm Dr. Anup Menon. Today I'll be talking to you about hypercalcemia and the various clinical scenarios where we encounter hypercalcemia, its manifestations, and also about vitamin D and calcium metabolism. Before going into hypercalcemia per se, I would like to give a few insights into how calcium is metabolized in the body, the role of vitamin D, the role of parathormone, and things like that, and only then I'll be going into the topic per se, otherwise it will be confusing. So the most important thing that you have to remember is there are two important things that maintains vitamin D and parathormone. It's vitamin D and parathormone which play a major role in the calcium metabolism. I'll just first talk to you about how the net effect of parathormone and vitamin D on the body, and I'll tell you how it happens, and then we'll link it with the various clinical scenarios. The net effect of vitamin D is to increase calcium and increase phosphate. Always when you send calcium, you should always send phosphate along with it, and the net effect of parathormone is to increase calcium and reduce phosphate. Okay, so whenever you see this combination of increased calcium and increased phosphate, the first thing that has to come to your mind is vitamin D. Always remember you have to send phosphate along with calcium, and when calcium is high and phosphate is low, and this combination, you have to always think about parathormone related causes. Okay. Now, I already told you how it happens. Now, we'll go into how this net effect of increased calcium and phosphate happens in vitamin D. Okay, I'll be talking about vitamin D first. Vitamin D, as you know, it has got two sources. It has got a plant source and an animal source. The plant source, which is known as ergocalicalciferol, and the animal source is known as cholecalciferol. Okay, so vitamin D, ergocalciferol, and cholecalciferol. So cholecalciferol, or vitamin D, gets converted into 25-hydroxy vitamin D, and this happens in the liver. And in the kidney, what happens? It becomes 125-dihydroxy vitamin D. This happens because of 1-alpha hydroxylase. 1-alpha hydroxylase is the enzyme. So that is why in a patient who has got a kidney failure, we directly supplement with cholecalciferol and not calcitriol. This is what is known as calcitriol. What you have to understand is if there is enough amount of enzyme, first it is 125-dihydroxy vitamin D which is formed, or cholecalciferol which is formed, and only after that 24-25-dihydroxy cholecalciferol is formed. Okay, so first enough amount of this is formed, and only after that if the enzyme is there, it will form into. And another important thing that you have to remember is 125-dihydroxy vitamin D3 causes bone resorption, and 24-25-dihydroxy causes bone formation. Okay, so this is how vitamin D. So I told you vitamin D is formed as cholecalciferol. It becomes 25-hydroxy cholecalciferol in the liver and 125-dihydroxy cholecalciferol in the kidney with the help of the enzyme 1-alpha hydroxylase. And 1-alpha hydroxylase, initially it is 125-dihydroxy cholecalciferol which causes bone resorption. 24-25-dihydroxy cholecalciferol is formed after enough of 125-dihydroxy cholecalciferol is formed, and it is also by the 1-alpha hydroxylase enzyme. And one important difference that you have to remember is 24-25-dihydroxy cholecalciferol causes bone formation by activation of osteoblasts, and 125, it is the activation of osteoblasts happens by the activation of bone proteins which are known as osteopondin and osteocalcin, and 125-dihydroxy cholecalciferol actually causes bone resorption, causing increased calcium and phosphate. Okay, now I'll tell you the action of vitamin D on the three different parts. Okay, so first action of vitamin D on the bone, then action of vitamin D on the intestine, and then action of vitamin D in the kidney. Okay, so the bone, as I told you, the 125-dihydroxy cholecalciferol, both vitamin D, that is this 125-dihydroxy cholecalciferol, as well as parathormone, activates something which is known as the rank ligand. Okay, it causes a rank ligand-rank interaction, as a result of which osteoclasts are activated, which causes increased calcium and phosphate. So the net effect in the bone is increased calcium and increased phosphate. As I told you, bone formation only happens after enough of 125-dihydroxy cholecalciferol is formed. So what is the action on the intestine? Intestine, via 1-alpha hydroxylase, 125-dihydroxy cholecalciferol is formed, and by calbindin. It causes increased calcium and phosphate by increased absorption of calcium and phosphate in the intestine. Okay, so that is its action on the intestine. What is the action on the kidney? The action on the kidney is vitamin D again causes increased calcium and increased phosphate. So increased calcium and increased phosphate in the blood means what? It has to reduce the excretion of both calcium and phosphate. So as you can see, the bone, intestine and the kidney, the action of vitamin D is to increase calcium and phosphate in the blood. In the bone, there is a separate action by 24-25 hydroxyvitamin D, which actually reduces the calcium and phosphate. But because it is formed only after enough amount of 125, that action predominates. So the net action of vitamin D will be increased calcium and increased phosphate, like I told you initially. Now what about parathormone? Parathormone also the same action in the bone. It causes bone resorption by increased calcium and increased phosphate. And increased calcium and increased phosphate, how does it happen? By, again, I told you the most important, I will talk to you step by step from how osteoblast, osteoclast and everything gets regulated. So for now, you just remember that the osteoclast recruitment happens because of a rank ligand activation, and the most potent activation of rank ligands are two things. One is parathormone and vitamin D. So increased calcium and phosphate in the blood is happening from the bone because of the bone resorption, and the parathormone is also no different. Just like vitamin D, it activates the rank ligand and causes resorption of the bone, increased calcium and phosphate in the blood. What about in the intestine? Okay, I told you about this enzyme 1-alpha hydroxylase. The most potent inhibitor of 1-alpha hydroxylase is something which is called FGF23, which is secreted by the osteocyte. We will be using that a little later. 1-alpha hydroxylase. I told you 1-alpha hydroxylase, it expresses something called calbindin. As a result of it, both calcium and phosphate are absorbed from the intestine. It is expressed on the jejunal cells of the intestine. Calcium and phosphate increases, and the net effect on the, what is the net effect on the kidney? Kidney is one place where it is different. It reduces the excretion of calcium and increases the excretion of phosphate. Okay, so this is the only place where the parathormone action is different. It increases the calcium in the blood, so it reduces the excretion of calcium in the kidney and increases the excretion of phosphate. Okay, this is the action in the kidney. So because of this particular action, the net action of parathormone will be increased calcium and reduce phosphate. Okay, so that's how we have come to that first thing. I told you when you have a hypercalcemia, you should also send for phosphate. You can have variable combinations. Both calcium and phosphate is increased. You have to think more of vitamin D cause, and calcium high and phosphate reduce, or other combinations. Mainly, you just remember this now. Increase calcium and reduce phosphate. You think about some causes related to the parathormone. Now, I'll give you a brief idea into the bone metabolism, which we'll be again using when we come to calcium metabolism in the kidney, because all this is interrelated to each other. Okay, so the bone initial formation is by the osteoblast. Osteoblast is the first thing that is formed. Osteoblast, it is a mesenchymal in origin, and the transcription factor responsible for the formation of osteoblast is something which is known as RUNX2. Osteoblast lays down bone matrix and forms osteocyte. And osteocyte, the important, I told you, it lays down the bone matrix to form the osteocyte. Okay, so if you ask me what is the key regulator of bone metabolism, it is always the osteocyte. So what all does osteocyte do? Osteocyte first of all secretes something which is known as the FGF23. Earlier I told you osteocyte secretes FGF23. FGF23, the two things that you need to remember is, first of all, it reduces phosphate because it's a phosphaturic substances, and it also inhibits 1-alpha hydroxylase. Where did we remember 1-alpha hydroxylase is the one which is necessary for the formation of 125 dihydroxyvitamin D from vitamin D. Okay, so basically for the action it is required. Okay, so that is the thing. And also the other thing that the osteocyte does is it inhibits the osteoblast. Okay, if you look at it, it inhibits the osteoblast by a WNT pathway. Okay, so it inhibits it acts on the osteoblast by the WNT pathway, secreting something which is known as the sclerostin. Okay, so you have to remember that what recruits the osteoclast. Osteoclast is recruited by the osteoblast by the activation of rank ligand. Which are the two important activators of rank ligand? Parathormone as well as vitamin D. Okay, so that is how. And osteoclastic activation causes resorption of the bone and increase in calcium and phosphate in the bone. And osteoblast, on the other hand, what it does, osteoblast actually results in bone formation. How does bone formation happen? By recruiting lesser osteoclasts, and lesser osteoclast is recruited by something which is known as the sclerostin. The osteoblast, again, just like how this thing secretes sclerostin, it secretes sclerostin and recruits less osteoclast, and bone formation is formed. Okay, here one important key thing that you have to remember is bone resorption. Bone resorption takes around 3 weeks only, and bone formation takes around 3 months. Okay, so bone resorption takes only 3 weeks, bone formation takes 3 months. So what can we derive from that? Whenever there is a heightened activity of osteoclast, the bone that is formed, just like how you have in your bone marrow a large amount of progenitor cells being formed, it doesn't give enough time for differentiation. Similarly here, because it takes 3 months for bone formation, if there is an increased activation of osteoclast, woven bone or amorphous calcium phosphate is formed instead of calcium hydroxyapatite, which is the thick bone. Okay, that point you have to remember here. So coming back to our point, parathormone causes increased calcium and reduced phosphate. That's how it will be seen. And vitamin D causes increased calcium and increased phosphate. Okay. I'll just give you a small briefing of whatever I've told till now. So both vitamin D and parathormone has its action on the intestine, bone and the kidney. And bone, we were talking about how it is 1-alpha hydroxylase which causes the activation of 25 hydroxycholecalciferol to 125 dihydroxycholecalciferol, and it is 125 dihydroxycholecalciferol which expresses calbindin and causes calcium absorption in the gut. It also in the gut or in the jejunal cells, it acts via something which is known as the TRPV5 and TRPV6. Okay. It is via the activation of, it is via these receptors. The same receptors are also present in the distal convoluted tubule of the kidney. That's how the thing happens. Okay. Now, a few important points about before going into the clinical aspects of hypercalcemia. Okay. So, what is the normal level of calcium is 8.6 to 10.3. Okay. Always you have to remember that 48% is ionized and 40% is bound to albumin. Okay, what is the problem if the 40% of thing is bound to albumin? You always have to do a correction. Okay, if depending upon the amount of the corrected calcium is given by the formula serum calcium plus 0.8 into 4 minus serum albumin. 0.8 into 4 minus serum albumin. That is the formula for corrected calcium. Okay, you have to always obtain the corrected calcium. Another important thing that you have to remember is whenever a patient has got hypercalcemia, it will always be associated with hypercalciuria. Okay, I'll just give you a small example. Whenever the calcium increases, there is a calcium sensing receptor that is present in the parathyroid gland. The calcium sensing receptor in the parathyroid gland senses this increased calcium and it will reduce the amount of parathormone that is being secreted from the parathyroid gland. When the amount of parathormone secretes is less, what it does, it causes reduced calcium by how? By, I told you the action of parathormone to increase calcium and reduce phosphate. So, it will reduce the amount of parathormone secreted. The same thing happens when the calcium reduces. When the calcium reduces, the parathyroid gland senses it through the calcium sensing receptor and increases the parathormone secretion. Okay, and as I told you, the link between the parathormone and vitamin D, parathormone activates 1-alpha hydroxylase, and 1-alpha hydroxylase is the one which is necessary for the formation of active form of vitamin D, which has its action on the intestine, the kidney as well as in the bone. In the bone, parathormone acts separately by activating something which is known as the rank ligand. So, in the bones, both parathormone and vitamin D activates the rank ligand, causing a rank ligand-rank interaction, and as a result of which the bone resorption happen. In the intestine, parathormone activates 1-alpha hydroxylase. So, parathormone is not acting directly, it is acting through vitamin D, through vitamin D, it will activate 1-alpha hydroxylase, and it expresses calbindin, and through TRPV5 and 6 it absorbs calcium and phosphate. And parathormone's action on the kidney, I told you, it causes reduced excretion of calcium and increased excretion of phosphate. So the net action of parathormone is because of its final action on the kidney, as a result of which there is increased calcium and reduced phosphate. Vitamin D, as I told you, separately it acts on the bone and all the three areas, some of which is because of the activation of parathormone, as a result of which the final action is increased calcium and increased phosphate. So the ultimate take home point is increased calcium, increased phosphate, think about parathormone. Think about vitamin D, increased calcium and reduced phosphate, think about parathormone. So I would like to give you a few values. What are the total body stores of calcium in the body is around 1000 to 1300 milligram. The amount of calcium that you get in the diet is around 1 gram, out of which 20% is absorbed, and the amount of calcium that you absorb is around 200 milligram, which is 20% of 1 gram, and around 4 milligram per kilogram is the amount of calcium that is excreted in urine. That also comes to around 200 milligram. Okay. Always you have to remember that hypercalcemia is associated with hypercalciuria because of the calcium sensing receptor that is present in the kidney as well as the parathyroid gland. In the kidney, the calcium sensing, the initial response is the calcium sensing receptor in the parathyroid, and the secondary response is the calcium sensing receptor which is present in the kidney, as a result of which hypercalcemia is sensed, and whenever there is hypercalcemia, calcium is excreted out more in the urine to maintain the balance constant. Okay, and the calcium value is tightly regulated up till around 4. Now I'll tell you in detail which are the places where calcium is handled in the kidney. Okay, in the kidney, calcium is handled in 3 places. 60% of the calcium is handled in the proximal convoluted tubule. It is a passive absorption of calcium. Then, as I told you in the presentation on hypokalemia, I had told you, there is something which is known as the paracellular pathway. Okay, so 60% in the proximal convoluted tubule, 20%, almost 25% in the paracellular pathway. Which is present in the sodium, potassium, 2 chlorides important. Okay. And the remaining 10% is in the DCT. Okay. And I told you TRPV5 and 6. TRPV5 and 6 are the receptors which causes absorption of calcium. They are the same receptors that are present in the intestine. It is expressed by calbindin and acted upon by 125 dihydroxy vitamin D. Similarly, in the DCT also it is the TRPV5 and 6. TRPV5 and 6, which is causing the final absorption of calcium. Okay. In the intestine, what you have to remember is the pathway that I told you, which expresses TRPV5 and 6 in the jejunal cell, is something which is known as a transcellular pathway. There is another pathway which is known as the paracellular pathway, which is a passive pathway. So, up till about 4 grams of intake, it is tightly regulated inside the by the various mechanisms that I told you about. Once the intake of calcium becomes more than 4 grams, what happens is you have something which is known as a milk alkali syndrome. So I told you whenever there is hypercalcemia, there is associated hypercalcia. So the condition where there is excessive dietary intake of calcium, as a result of which you have hypercalcemia and hypercalciuria, is known as milk alkali syndrome. There is also a variant to it. Sometimes you just think about a loss of function mutation of the calcium sensing receptor which is present in the kidney. Whenever there is hypercalcemia, hypercalciuria is because calcium sensing receptor is working properly. When the calcium sensing receptor is not working properly, you have familial hypocalciuric hypercalcemia. Okay, so these are the 2 conditions that has to be remembered along with it. Now, so let us write about the various combinations that are possible. Okay, so initially, so calcium, you have found the corrected calcium is more than 10.4. Okay, you also send along with phosphate. If the calcium is high and phosphate is low, I told you it is related to parathormone. If the calcium is high and phosphate is also high, it is usually associated with vitamin D. You can also have other combinations. You can have low calcium, high phosphate, and also high calcium, high phosphate. Both these happen in CKD. Okay. So initially you see a patient. So how do you suspect hypercalcemia in the first place? Okay, so you would have seen in textbooks bones, stones, abdominal groans and psychiatric moans. Patient can present with fatigue, patient can present with bone pain, a patient can have stone formation all over the body, abdominal pain because of the pancreatic ducts being blocked by calculi and pancreatitis, and neuropsychiatric manifestation. These are the usual clinical presentations of hypercalcemia. So you see hypercalcemia, send the clinical presentations which can suggest hypercalcemia, you send the calcium value. If it is more than 10.4, you look at the serum albumin and look at what the corrected calcium is. If the corrected calcium is still coming more than 10.4, you also send along with that phosphate value. If the calcium is high and phosphate is low, you have to think about parathormone. Which are the conditions where parathormone can increase? Parathormone can increase either in a primary hyperparathyroidism. What is a primary hyperparathyroidism? It is a condition where, so you're taking the first combination, high calcium, high phosphate. High calcium, high phosphate. What are the possibilities? Sorry, high calcium and low phosphate. It is related to the parathormone. Okay, the normal level of parathormone is around 50 to 100 picogram per ml. Okay, so if you see that the parathormone is raised to around 300, okay, or 600, okay, what are the three possibilities? So parathormone is elevated. It can be because of a hyperparathyroidism is the diagnosis, and it can be because of a hyperplasia, it can be because of an adenoma, it can also be because of a carcinoma. Hyperplasia is usually associated with a Menon syndrome, and for the treatment of that is removal of 3.5 parathyroid gland. If the parathyroid, if it is an adenoma, you have to remove the adenoma. One thing that is normally said is the drugs which are used for the treatment is not very beneficial. You can just reduce it symptomatically by the treatment modalities that I will be telling you. Do a removal of parathyroid gland. That is the treatment for hyperparathyroidism. Suppose when you're checking the calcium is high and the phosphate is low and the parathormone is coming low, then you have to suspect something which is known as the humoral hypercalcemia of malignancy. Okay, PTH-RP related. Okay, suppose you have squamous cell carcinoma of the lung, squamous cell carcinoma of the head and neck, cervix. All these things can cause a PTH-RP related. So when the PTH-RP is high, you will see that the PTH is low. Okay, excess PTH-RP will suppress the PTH, and also the usual combination of calcium high, phosphate low will be obtained. Okay, now next I'll be talking about another combination. Suppose the patient has got reduced calcium and increased phosphate. Okay, so I told you parathormone action on the kidney is to increase the calcium and reduce the phosphate, because it reduces the excretion of calcium in the urine and increases the excretion of phosphate. So suppose the patient has got a CKD. What will happen? You will see this kind of a combination, that is increased calcium and reduced phosphate. Okay, so why does this combination happen? So initially when the CKD starts, that is stage 2 CKD is around when the GFR becomes around 60 to 90. When the GFR becomes around 50, what is happening is the parathormone is being secreted and the vitamin D is also acting, but it is not able to act on the particular areas of the kidney. I told you in the DCT and on the corresponding areas of the kidney it is not happening. So as a result of which the phosphate excretion is not happening. Now phosphate excretion, if it doesn't happen, if it accumulates in the blood, there is a small problem. It will convert the endothelial cell into osteoblast, and it will cause a lot of calcium trapping, which can be extremely dangerous for a patient with kidney disease. So because it is extremely dangerous for a patient, there is one adaptive mechanism that happens, that is osteocyte secretes FGF23, as I told you. So FGF23, as I told you, is a phosphaturic substance. So the phosphate was supposed to increase, but it doesn't increase because FGF23 is trying to excrete it out in the urine. But FGF23, the problem is it inhibits 1-alpha hydroxylase. Because it inhibits 1-alpha hydroxylase, what will happen? Because it inhibits 1-alpha hydroxylase, vitamin D is not formed, and the calcium and phosphate absorption from the intestine doesn't happen. Okay, so initially you can see the combination of low calcium and normal phosphate and an increased PTH. Okay, this condition is known as secondary hyperparathyroidism because it is seen in early CKD. Okay, and the mechanism I told you, it is a parathyroid excess because of parathyroid resistant. Parathormone is not able to act on the corresponding area of the kidney. It will initially present with a high calcium normal phosphate, and then it will present with this combination, that is high calcium and low phosphate. And after the CKD progresses for a particular amount of time, the PTH continues to keep on acting, resistance happens, and the amount of PTH will be extremely high, that is secreted from the parathyroid gland, and that is known as tertiary hyperparathyroidism. In that, it will start behaving like an adenoma, and again calcium and phosphate will become high. Okay, so hypercalcemia, clinical features, when you see after the corrected calcium, you see it is more than 10.4. You look for the phosphate value. Calcium and phosphate high means vitamin D. Calcium high and phosphate low means parathormone. If the parathormone is low, you think of paraneoplastic causes. If the parathormone is high, you think of a parathyroid adenoma, hyperplasia, carcinoma. How do you deal with the parathormone related thing? Do a PET scan and localize where the parathormone related, usually I told you it's a squamous cell carcinoma of the lungs, cervix and head and neck. Localize and treat accordingly. Okay. And the other combination, when the calcium is low and phosphate is high, you think about early CKD, calcium high and phosphate high with parathormone high with the evidence of CKD. I've told you how it happens. Okay. Then you look at the next combination, increased calcium, increased phosphate. When you look at increased calcium and increased phosphate, I told you, you have to always look for causes of vitamin D. Okay, vitamin D again has two components, 25-hydroxy vitamin D and 1,25-dihydroxy vitamin D. If both these are increased, then what do you mean? It means that because generally for female patients who are post-menopausal, we usually supplement vitamin D. Also, it has got an anti-keratinocyte effect on the cancer cells, so it is protective against breast carcinoma, cervical carcinoma and things like that. So, iatrogenic cause of vitamin D, if you're taking excessive vitamin D, that can lead to hypercalcemia with hyperphosphatemia with elevated 25 and 125-dihydroxy vitamin D. Suppose that vitamin D is elevated and 25-hydroxy vitamin D is normal and 125-dihydroxy vitamin D is elevated. What does it mean? It means that this is a condition that can be seen in certain malignancies as well as certain granulomatous conditions. Suppose the patient has got a sarcoidosis, that granulomatous lesion, the cause of hypercalcemia is excessive secretion of 125-dihydroxy vitamin D3. Also you can see in lymphoma. Okay, so that is about it. Suppose the patient has got hyperparathyroidism. I told you usually the symptoms of the patient can have either fatigue, he can have bone pain or muscle weakness, he can have stone formation all over the body, abdominal pain because of pancreatic calculi and pancreatitis, and also neuropsychiatric manifestations. In the CNS manifestations, one important thing that you have to remember is neuropsychiatric manifestations are more common in hypercalcemia. Hypercalcemia doesn't manifest per se with an encephalopathy or raised intracranial tension like how it is seen in hyponatremia and other things. More of a specific neuropsychiatric manifestation is seen. Okay. So, if the patient doesn't have any of these symptoms, if the patient is asymptomatic, what are the criterion that decides if the patient has to undergo a parathyroidectomy or not? Okay, so if the calcium level is more than 1 milligram per deciliter from the baseline, or if the patient's age is less than 50 years, or the patient's bone mineral density is low, or if the patient's GFR is less than 60. Okay, these, if the patient has got hypercalcemia, you see that you detect hypercalcemia, clinically patient is asymptomatic, and you see that the parathormone levels are elevated, and you see that the patient has got an adenoma or hyperplasia, whether to do a thyroidectomy or parathyroidectomy is dependent on these factors. Only if these criteria are satisfied, you need to do a parathyroidectomy. And for sarcoidosis and malignancy, again, you have to do a PET scan and other investigations, keeping those things in mind. Okay. Now, what is hypercalcemic crisis? So I told you bone stone, any of these classical presentation pressing in a catastrophic manner. If the patient is feeling extremely tired and is looking dehydrated, it can be a hypercalcemic crisis. You have to know how to treat a hypercalcemic crisis. Whenever I told you in the class about sodium, just like sodium, calcium is also an effective solute. It makes the patient extremely dehydrated. So as a result of which, the first thing that you have to do is aggressive hydration. Okay. Aggressive hydration you have to do, you have to give around 500 ml per hour of fluids. Okay, aggressive hydration, you can give NS or RL. Okay, and the next step that you can do is you can give calcitonin. Four unit per kilogram BD. Okay, calcitonin 4 unit per kilogram. If the patient is around 60 kg, 6 into 4, 24, 240 units BD you can give subcutaneous. Okay. Now, the other things that can be tried is bisphosphonates. You can give zoledronate 15 milligram in 200 ml normal saline over 4 hours. Okay, that's how you manage it. You can also give pamidronate 60 to 90 milligram over 2 hours. Okay, so that is how you manage hypercalcemia. So briefing into the entire session, hypercalcemia, clinical manifestation is bone stones, abdominal groans and psychiatric moans. Sometimes the presentation can be just with fatigue. And whenever you see a cluster of these symptoms, you should keep hypercalcemia in mind. The normal level of calcium is 8.6 to 10.3 and you have to do the corrected calcium depending on the serum albumin by the formula that I had mentioned. And after obtaining the corrected calcium, if the calcium is high, always send phosphate along with calcium. There are multiple combinations that can occur: calcium high with phosphate high, calcium high with phosphate low. Calcium high with phosphate low should always make you think about parathormone and related causes. Send for the parathormone levels. If the parathormone levels is high, you have to keep hyperparathyroidism in mind. Primary hyperparathyroidism can be because of an adenoma, carcinoma or hyperplasia. Do a technetium sestamide scan or a parathyroid scintigraphy as it's called to view whether it's a hyperplasia. Usually parathyroidectomy is the treatment, and in certain conditions whether parathyroidectomy is indicated or not, especially in asymptomatic patients, you have certain criteria which I had already told you. And then if the calcium and high and phosphate is low but parathormone is low, it could be related to the parathormone related peptide, which is usually paraneoplastic. I told you squamous cell carcinoma of the lung, of the skin and the cervix. Do a PET scan, localize the lesion and treat accordingly. And if the calcium is high along with the phosphate high, you have to think about vitamin D. Vitamin D, I told you, it is formed in the liver, 25 hydroxy vitamin D3, 125 dihydroxy vitamin D3 in the kidney. So you can have variable combination. Either if both 25 and 125 hydroxy vitamin D3 is elevated, you have to think about iatrogenic, because many people will be supplementing vitamin D. Just stop the vitamin D. If only 125 dihydroxy vitamin D is elevated, you have to think about granulomatous conditions, sarcoidosis and lymphoma, and proceed with the investigations accordingly. And if the patient has got features of kidney disease, you will have other combinations which is known as secondary and tertiary hyperparathyroidism. Secondary hyperparathyroidism occurs in chronic kidney disease, early stages of chronic kidney disease. You have low calcium and high phosphate, and at the later stages of kidney disease, because it starts behaving like an adenoma, you will have high calcium and high phosphate. And the mechanism how it happens, I had already told you. And also you have to remember about how the parathormone and vitamin D plays a role in the metabolism. Vitamin D, the action on the bone is by activating the rank ligand rank interaction, osteoclastic activation, increase in calcium and phosphate in the blood by mobilizing it from the bone. The action of vitamin D in the intestine is to form cal binding and absorb calcium and phosphate. The role in the kidney is again via TRPV 5 and 6 by vitamin D in the DCT. So the net effect is increased calcium and phosphate, 24-25 dihydroxyvitamin D3, the action is directly reversed, but only after 125 dihydroxyvitamin D is formed, 24-25 dihydroxy D3 will be formed. So the net effect will be always increased calcium and increased phosphate. Parathormone also the same thing. In some areas it is acting along with vitamin D, some areas it's acting alone, and it causes increased calcium and reduced phosphate, and this is because of its action on the kidney. It increases excretion of phosphate and reduces the excretion of calcium. Okay, so I think that sums up the whole session.